Jenna, can you hear me?
I can. Can you hear me?
Yep, we can hear you and see you. So we're going to get started in about 5 minutes.
Perfect. Okay, great. And you can see the presentation okay?
Yep, technology is a wonderful thing.
All right. You'd think after a couple years of this, I'd be more confident.
All right, let's get started back again so we can get through with this. First, we're going to mention that after this presentation, we may just do away with the networking, 15-minute networking break and go straight into the next presentation so we can get out of here a little early this afternoon, since we had a few minutes just then. We're going to finalize it and find out if we can get it done after this. It is a definite. Okay, so we're going to go straight from here to the next one, and then we'll finish up a few minutes early this afternoon. Our next presenter is Ms. Jenna Bluestein on lowering barriers, increasing access, helping patients start and stay on buprenorphine treatment. She's a senior associate with the Pew Charitable Trust, working on the Substance Use Prevention and Treatment Initiative. Ms. Bluestein holds a master's degree in public policy from the Johns Hopkins Bloomberg School of Public Health and a bachelor's degree from Wesleyan University.
Hi, everyone. Thanks so much for having me. Can you hear me okay? Okay. My name is Jenna Bluestein. As you said, I work on substance use prevention and treatment at the Pew Charitable Trusts. And today I'll be talking about lowering barriers and increasing access to buprenorphine, a medication treatment for opioid use disorder. Just for a little background on who we are, Pew is a global research and public policy organization. We're an independent, nonpartisan nonprofit that uses analytical research to improve public policy and inform the public. We have a number of different projects and programs focused on a wide variety of issues affecting state governments and the environment. We like to say we study everything from pensions to penguins. And as we said, the specific program I work on is called the Substance Use Prevention and Treatment Initiative. And this project is dedicated to developing policies that expand access to effective treatments for substance use disorder, specifically on increasing use of FDA-approved medications for opioid use disorder and treatment. And so our work includes a variety of research projects and technical assistance to state governments. So to get into the three medications, we have methadone, buprenorphine, and naltrexone. So they're listed here in the order in which they were FDA approved for use. I'm sure you all are pretty familiar with these. We know these medications to treat opioid use disorder help people manage withdrawal symptoms, reduce illicit opioid use, and help folks stay in treatment. And then specifically, methadone and buprenorphine have also been shown to reduce risks of death from opioid overdose and to reduce risk of overall mortality by up to 50%. And additionally, by reducing injection of illicit drugs, buprenorphine and methadone have also been shown to decrease transmission of infectious diseases like HIV and hepatitis C. As far as accessing these medications, methadone can only be dispensed by licensed opioid treatment programs, or OTPs. Buprenorphine and naltrexone can both be prescribed by primary care doctors, although providers are required to get a special waiver for buprenorphine, and I'll talk more about that in a bit. So given that all of these medications work differently and are available in different settings, the right medication will vary for each person. So our project is really focused on increasing access to all three medications that patients have a choice in their treatment. But today we'll talk specifically about accessibility of buprenorphine. So just for some background on the issues we're working to address, we know the provisional data from the CDC predicts that about 95,000 Americans died of an overdose in the 12-month period between February 2020 and February 2021. And nearly 3/4 of these involved an opioid. So we're seeing these increasing overdose deaths during the pandemic. But even before COVID, an estimated 1.6 million Americans had an opioid use disorder, but only 18% received medications in their treatment for opioid use disorder. And we know that medications are the gold standard. So really, even before the pandemic, our treatment system really wasn't meeting the needs of people suffering from OUD. So we have this record number of people dying from opioid overdose, and we have a treatment that we know works best to reduce mortality, but we're underutilizing it. And so that's really the focus of our project, is to increase uptake of these medications and treatment. So what are the barriers to increasing access to buprenorphine treatment? We have a medication that works. We clearly have people who need it. So where is this disconnect? At the federal level, we have a significant barrier, the X waiver. And the X waiver is a special license from the DEA. It's separate and in addition to a DEA license for prescribing controlled substances. And providers need to apply for this in order to be permitted to prescribe buprenorphine. So when I'm talking about the X waiver, I'm referring not just to the license itself, but also the required training and the application process and continued DEA oversight that really all come with being a buprenorphine waiver provider. It's a time-consuming process, and as I'll get more into in a bit, not a lot of providers are choosing to become waivered. So in essence, it's kind of an opt-in system where providers get to choose whether or not they provide evidence-based treatment to their patients with opioid use disorder. And it's really worth mentioning that these rules don't apply for prescribing buprenorphine or other opioids to treat pain. So this waiver really singles out addiction medicine. Then at the state level, there are a number of utilization management policies and treatment program regulations that impede access to buprenorphine as well. And these either prevent buprenorphine from initially being prescribed in a timely manner, or by placing conditions on patients that make it harder for people to stay in and complete their programs. State funding mechanisms for buprenorphine treatment can be a hindrance as well. So if providers are not being properly reimbursed for prescribing medication, or if the reimbursement structure does not support coordinated or team-based care, that can be a problem for providers as well. And of course, the biggest barrier is always stigma. There's patient self-stigma, there's stigma within recovery communities that somehow being on medication treatment is not being seen as fully abstinent or not being fully in recovery, which we really know is not the case. And there's stigma against buprenorphine among providers and health systems as well. And that really leads to the reduced capacity to provide this treatment. And the stigma contributes to fears of buprenorphine diversion as well. There tends to be a bias against people with OUD, that they're untrustworthy patients, and increasing the availability of buprenorphine will only lead people to misuse it. But we already know this isn't happening in practice. So there was actually a new NIDA-funded study just released last week showing that buprenorphine misuse among people in treatment for OUD actually decreased from 2015 to 2019, despite all the increases in buprenorphine prescribing. The study also came to the same conclusion as a lot of studies before it, that people who do misuse buprenorphine do so because they are in need of, but not receiving treatment. So they are self-treating or preventing withdrawal. So all this information that we have indicates that fewer barriers to buprenorphine might actually decrease diversion and misuse. So a lot of these practices at the federal, state, and program levels really aren't providing the benefit that I think maybe where they were intended to. So if we look at the X waiver data, I think these stats really show how this process that was really intended to increase buprenorphine access is actually hindering its availability now. So much has changed in the 2 decades since this waiver process was put in place. We've seen the opioid epidemic worsening. We've had an abundance of research showing the efficacy of buprenorphine now, and yet we haven't really changed anything about the way we're providing buprenorphine in primary care. And in fact, in 2020, still only about 6% of active physicians had a waiver to prescribe. And the small number of available prescribers are not spread out evenly across the country. So we see these large gaps in certain counties and specifically rural areas. A 2020 Office of Inspector General report found that 40% of US counties did not have a single waiver provider to prescribe buprenorphine. And that same report found that nearly half of counties identified as having a high need for buprenorphine services had inadequate capacity to reach patients. And the majority of those are really in rural areas. So these gaps mean that almost 20 million Americans live in counties without a single X-waiver physician to prescribe buprenorphine. And stigma is really a big part of this as well. So we know from the literature, providers report not wanting to become waivered. They don't want to be inundated with those patients. A 2019 national survey of more than 300 primary care physicians found that only 20% of them indicated they were even interested in treating patients with OUD. So it's pretty clear that as long as we continue this opt-in waiver system, that we have to acknowledge the majority of providers are choosing to opt out. But there is some good news. We are seeing a number of activities going on at the federal level to address some of these access issues. I think a big one right now is interest in keeping some of the flexibilities that were given for prescribing buprenorphine via telehealth during the pandemic. So there were regulatory relaxations from SAMHSA and the DEA that removed the need for an in-person visit prior to prescribing buprenorphine. It's removed a large barrier for people with OUD living in those counties I just talked about who don't have an X-waiver provider, or even for people who maybe might have not chosen to go to the doctor in person for fear of stigma. So it also allowed patients to use audio-only technology, which has been really important. Approximately 14.5 million Americans live in digital deserts due to inequities in broadband access, digital literacy, and health system barriers. And we also know that audio-only encounters are more likely for patients who use public insurance or who are in self-pay status. So this indicates that this population of people might be less likely to have access to the video technology needed for audio-visual telehealth visits. So making these changes permanent is a pretty high priority, and I do think there's pretty good interest at the federal level. We also have new guidance released from SAMHSA around April 2021. So it's relatively new still, that allows providers to prescribe buprenorphine to up to 30 patients without the X-waiver. So essentially, providers give SAMHSA a notice of intent that they would like to start prescribing buprenorphine, but they no longer need to attest to receiving training if they only intend to prescribe to 30 patients or less. So this removes a barrier for providers who maybe only see a few patients with OUD who might have not gone out of their way to become waivered otherwise. Though if providers do end up wanting to prescribe to more than 30 patients, they'll still need to go through that typical waiver process. But that's really as far as SAMHSA can go as far as lessening the burden of the X-waiver without an act of Congress. And so since the X-waiver was created by legislation, it needs to be removed by legislation. And that's where the Mainstreaming Addiction Treatment Act, or the MAT Act, comes into play. And the MAT Act is bipartisan legislation that would remove the X-waiver requirement for prescribing buprenorphine entirely. So a lot going on at the federal level right now. So along with these policy changes, needs to come an attitudinal shift to address stigma toward people with OUD and toward buprenorphine if we're going to increase access. So for a long time, there have been myths about treatment readiness or hitting rock bottom, implying that people are only willing to accept treatment as a last resort. But we know that that's not the case. It's just people with OUD can't conform to a one-size-fits-all treatment system that isn't really meeting their needs. And so that's why we have such a great opportunity here with buprenorphine. The original intent behind allowing it to be prescribed in primary care, by allowing it to be prescribed by doctors, nurses, physicians' assistants, is that people should be able to find and initiate treatment easily. And yet a lot of state policies are still keeping buprenorphine under lock and key. So patients are having to go search for treatment rather than having treatment meet them where they are. And we're going to talk about lower threshold treatment models, which aims to fix that, which aims to meet people where they are and make sure that they're able to get treatment no matter where they are in their substance use journey. So lower threshold treatment models focus on initiating patients onto buprenorphine quickly and making sure that they can stay in treatment so that they're able to complete programs successfully. And so this includes initiating treatment as soon as someone is interested, providing medication without requiring any sort of concurrent services, and eliminating punitive practices in treatment. So this is pretty much in contrast to the experience in a lot of specialty treatment programs historically that have involved referrals and long wait lists and requirements that patients needed to meet, usually a certain number of counseling sessions per week, or providing negative urine drug screens, or they would face termination from their treatment programs. And even more, a lot of these programs, we've relied on residential programs that require people to live away from home, sometimes far away from home for many months. And so these conditions on engaging in treatment really make it difficult for people to start and stay in care. But with buprenorphine, there's an opportunity for people to indicate their interest in treatment, right where they are, and get them started right then and there. And we know how important this timing is now, especially with fentanyl overtaking the drug market, fentanyl being so potent and being the cause of so many, this rise in opioid overdoses, that we know every day someone's on a wait list, they're at risk for overdose. Every day someone's waiting for medication treatment, they're at a higher risk for overdose. And so by removing these barriers to buprenorphine initiation, we're making sure that people are able to stay alive. And it also opens the door for expanding treatment into non-traditional care settings, like emergency departments or harm reduction programs, where people with OUD are already showing up every day. It's also important to talk about how the rarity of buprenorphine availability and the stringent conditions of treatment have really made buprenorphine treatment a privilege for mostly white middle-class patients. Studies have shown that Black patients are less likely to receive a buprenorphine prescription than white ones, and that patients on Medicaid are more likely to be turned away from programs that offer medication. And this type of exclusionary access can lead to cash-only clinics or underground markets that really put underserved populations at risk. And then, on the other hand, we have low threshold treatment approaches that put fewer conditions on treatment that allow people who maybe, for example, are experiencing housing insecurity or homelessness, and they can connect to treatment without placing unrealistic commitments on this population that has a lot of competing needs. And so low threshold models can also offer a less punitive approach, particularly for people of color who've been historically pigeonholed into opioid treatment programs receiving methadone. And those programs require daily visits and sometimes even observed urine screenings. And so buprenorphine access is really an opportunity to close treatment gaps, but to also offer people treatment with dignity. So now to get into the nitty-gritty, what are some of these policy solutions that address how buprenorphine treatment programs function? So the first solution is to a problem that always comes up with providers, which is how we pay for treatment. And so particularly making sure patients can be initiated on buprenorphine as soon as they are interested in treatment. And one of those barriers is prior authorization. I'm sure you've heard of prior authorization. It's typically used to make sure providers can justify the need for a specific treatment, but we know that's not necessary for buprenorphine. The evidence is clear. This medication is a first-line treatment. It's always going to be the appropriate course of care for opioid use disorder. So it's really not necessary to cause this delay of care with a prior authorization, and states can remove that requirement. There are other policies states can look at as well, changing billing requirements to allow providers up to 30 days to complete an intake assessment rather than having to submit one before they prescribe. So a lot of times, there's these lengthy intakes that providers have to submit before a patient is able to get a prescription. And so it's really a matter of removing any of these roadblocks so that patients can go to a provider and leave with a prescription. And that's really the end goal of a medication first approach to treatment. So once patients are initiated on buprenorphine, it's crucial to ensure that they remain on medication for as long as is therapeutically beneficial. Since opioid use disorder is a chronic condition, requires ongoing care, there's really no specific length of time someone should be in treatment, and at no point should they be forced off of medication. Yet some states are still placing requirements in their payment policies that are dictating this care, decisions that should really be up to a provider and patient. So for example, tapering plans require practitioners to reduce the dose of buprenorphine over time until the patient's no longer taking it. And the practice really interferes with recovery, and it puts patients at risk for overdose once they've stopped the medication. Similarly, some states dictate daily dose limits for buprenorphine, but we know some people don't respond as well to treatment if they're being underdosed. So no state should really be dictating to providers, what dose of buprenorphine to give, and they certainly shouldn't be creating maximums that are below the suggested maximum. And so according to the American Society of Addiction Medicine, the suggested maximum daily dose is 24 milligrams per day. Although states could even consider allowing larger doses, especially with fentanyl being so potent, some folks might require a bit more if they have a higher opioid tolerance. And so, for example, Washington State permits prescribers to give up to 32 milligrams of buprenorphine per day. There's also the issue of requiring concurrent services. So it's usually counseling. Even though we have evidence that shows people taking only buprenorphine don't have significantly different outcomes from patients who also receive behavioral therapies. So really this idea of the required counseling is kind of a relic of the medication-assisted treatment days, but we've really moved past that language. We understand that medication is treatment, and so buprenorphine should really be the first priority. I think there's been some confusion among state officials and providers about how federal regulations deal with this issue. The federal regulations really only regulate treatment programs. They're not regulating patient behavior. So practitioners need to have the capacity to refer patients to behavioral health services, but there's no obligation for patients to use those services. So for example, even the 2020 National Practice Guidelines from ASAM state that a patient's decision to decline psychosocial treatment or the absence of available psychosocial treatment should not preclude or delay pharmacological treatment of OUD. So we know here, patients should be able to receive buprenorphine without any requirements of concurrent services. So they should obviously still be offered. So some states have addressed these issues by removing proof of counseling from prior authorizations, increasing administrative reimbursement rates for prescribing buprenorphine so that the practice on its own is financially feasible for providers, and by re-examining payment bundles for buprenorphine related services. So you're not like inadvertently requiring counseling just by the way you're reimbursing providers for services. in addition to medication treatment, there may be wraparound services that would benefit patients with opioid use disorder. I think this is something that comes up in the literature a lot, that providers, would appreciate having more ability to address some non-medical concerns of their patients. And so there's, one innovative approach to this is the Massachusetts Collaborative Care Model, which integrates nurse care managers into federally qualified health centers, and they can help patients with insurance or pharmacy problems, legal issues, housing, and that's all while billing Medicaid at the same rates for those buprenorphine initiation visits. So they're really able to provide a bit more comprehensive patient-centered care. And 5 years after that model began, buprenorphine treatment admissions had increased 7-fold, and they had good patient retention with that model as well. Another interesting example is the REACH program in New York State. It's a low threshold and kind of harm reduction based model that was able to become a certified outpatient treatment center with the state, so that they were able to start billing Medicaid for a variety of their services that were including the medical services. So they have integrated primary care, and they provide medications for opioid use disorder, but they're also billing for community health worker services and peer outreach. We also now have great examples of what a treatment system could look like with fewer regulations on buprenorphine because of all the regulatory relaxations during COVID. So as I mentioned before, providers have been newly able to initiate buprenorphine without an in-person visit and using audio-only technology. And this has really enabled providers to reach new people. So a nationwide survey of buprenorphine waiver clinicians that was done during the pandemic found that those who prescribed over the past year, nearly 1/3 of those prescribers had prescribed to a new patient via telehealth without the in-person visit. And only 5% of them reported any difficulties with buprenorphine initiation. So we're really seeing that this has been a pretty easy and successful transition for a lot of buprenorphine prescribers. And one interesting example of how you can use telehealth for kind of low threshold treatment models is the New York City Health and Hospitals virtual buprenorphine clinic. So they launched a same-day initiation via telemedicine program. Patients can use video conferencing or audio only if they don't have a smartphone. And they can engage patients from their own health and hospital system, but they were also able to recruit from homeless shelters and from a jail reentry program. So they had a pretty wide reach. And in just 9 weeks of clinic operation, they started 78 patients on buprenorphine treatment. And there were very few adverse clinical outcomes, which I think is pretty standard for these programs. And though diversion is always stated as a concern here, the study and others haven't found any indication that telehealth prescribing of buprenorphine increased diversion at all. So that's always good to know. There's also a similar initiative in Rhode Island, which had a 24-hour telephone hotline. And they were able to connect people with OUD with buprenorphine prescribers over the phone, who would initiate them with a prescription and then connect them to community providers for ongoing maintenance care. And those patients who called the hotline said they would have probably not otherwise engaged in treatment had that option not been available to them. So this is really making a big difference for people who want to engage in treatment, but might otherwise face some of the barriers we talked about earlier about trying to start and stay in treatment. And of course, we always have to consider measurement and evaluation. Q is very measurement focused. And so we often measure treatment outcomes based on the more strict conditions of treatment, like abstinence from illicit drugs. But if we shift our approach to treatment, then it would follow that we would need to shift our approach to how we define success in treatment, what successful outcomes look like, and what it means for patients to get better on their own terms. One way that researchers have approached studying outcomes, particularly for low threshold treatment models, is by looking at reduced use versus abstinence. So if a patient is able to significantly reduce their use of illicit drugs compared to when they first started treatment, even if not maintaining total abstinence, it's still a positive outcome, particularly when reduced use means lower odds of fentanyl overdose, and keeping people alive should really be our main goal right now. Researchers have also looked at treatment retention in terms of days covered in treatment rather than consecutive days in treatment. So we know that a lot of the populations of people we're trying to reach may be more likely to experience disruptions in care. So, if people are housing insecure, then they might not be able to stay in the location where their treatment program is, all the time. So while it may be unrealistic to measure success based on uninterrupted periods of time, being able to show that patients were in treatment, filling their prescriptions, more days than not is still a win, I think, for treatment. And so that's kind of the end of my spiel about increasing access to buprenorphine and removing some of these barriers and thresholds to care. Here are the citations for some of the data I mentioned more toward the beginning of the presentation. They cover like the scope of the problem and the gaps in X-waiver providers. And then I also want to make sure that everyone knows the information about low threshold care I presented here is also a written issue brief available on the Pew website. So it's called Policies Should Promote Access to Buprenorphine for Opioid Use Disorder. I have a little screenshot here of what it looks like. So if you want more detail, you want citations, you can go ahead and access that publication on pewtrust.org/substance misuse, which is our project website. Or also feel free to reach out to me directly. My email is on the screen. And I'm going to try and take some questions now. Hopefully it all works via Zoom, because I'd love to engage with all of you. And thank you so much for your time.
Okay, any questions in the room?
Hi, Jenna. This is Nick Reuter from Indivior. In full disclosure, we manufacture buprenorphine treatment products. And we followed the SAMHSA change in the patient limit and the X-waiver issue. And just on slide 7, the second bullet indicates they don't need to get the waiver, and they actually still need to apply for and get the waiver. They just lowered some of the criteria for obtaining the waiver. I think it's an important distinction because the previous administration proposed to do away with the waiver requirement at all if you agree to treat 30 or fewer patients, and only for physicians, not for nurse practitioners or physician's assistants who also have this authority. And I checked with SAMHSA to see if that April 2021 really had much of an impact and more practitioners obtaining the X-waiver authorization, and it hasn't really had much of an impact. And I think one of the things you put down there about the changing the legislation might have a more significant impact. But I have to tell you that after years in this area, it's not really the waiver requirement that really affects how many practitioners want to help this patient population. It's some of the other things you pointed out, reimbursement issues. Many of them want to provide the counseling that ensures great outcomes, but they can't find the resources for it. There's just not enough treatment resources. And finally, the one you highlighted about stigma is significant. And I'm wondering if the Pew Charitable Trust has any specific initiatives in place to address stigma in general, but really the stigma in healthcare professionals who don't really want or see the need to treat this patient population. Thanks.
Yeah, thank you for that comment. I think You're right about the SAMHSA notice. So they call it a notice of intent now, I believe. It's like a waiver for the waiver. So you still have to apply with SAMHSA, correct? But you don't have to attest to all the different requirements for the formal waiver process. I think my team at Pew will actually be looking into the number of new waiver providers since that guidance went into play. I mean, I think it's tough because, you know, SAMHSA releases guidance and then they have to educate all providers about it. And then you kind of have to wait to see what happens. So we're still, you know, not that far out, but I do think Pew will be looking into the number of new waiver providers to see if there were significant increases. It's definitely something we're interested in studying as well. I think as far as the waiver not being the, you know, there are a bunch of other barriers in addition to the waiver. And I think that's, you know, totally correct. The waiver is one of many issues. I think from Q's perspective, from what our team is working on, we really see the waiver as contributing to a lot of that provider stigma. I think it sends the message that you know, treating patients with OUD is somehow different, and it must be hard if you have to like go through all this extra training and have to do all this extra stuff just to prescribe buprenorphine. And that's really not the case. If you talk to providers who are already prescribing, it's not that much different than managing other chronic conditions with medication. And so I think, you know, from our perspective, the waiver kind of contributes to that, and getting rid of the waiver is one important step in being able to fix the rest of those things, right? That the stigma attached to the waiver is also affecting all those other barriers you mentioned as well. So we also, we work with some provider groups, and we do work with state governments. So we talk to a number of stakeholders in the states we work in, and we do try to address stigma that way as well by doing, you know, legislator education and provider education on the benefits of medication treatment.
Any other questions?
Hi, my name is Shannon. I'm with Morrison Dixon, a wholesale company. And I wanted to ask two questions. One is, most of your recommendations for lowering the barriers, does that apply to buprenorphine pure and naloxone, or only the naloxone, the one containing the naloxone? And then the other question I was going to ask, if the barriers are lowered and we see increased prescribing, how will that affect wholesalers that have to monitor orders? And when we see increased orders from pharmacies for buprenorphine, that kind of becomes a challenge for us. So how are we to monitor those orders?
Those are great questions. I can definitely take the first one. So I think we don't really have a particular opinion about what type of buprenorphine product people are using. I think buprenorphine has pretty much become the go-to for most places. I think the bupe formulation without naloxone has become the one that states tend to keep a prior authorization on. Sometimes it's used for pregnant people in treatment. We don't really take an opinion on that necessarily. There's also injectable buprenorphine. So there's a lot of different ways to provide that treatment. And I think it just depends on the provider and the patient, you know, what is best in that scenario. I do think that the buprenorphine, I assume it's the lower rates of misuse is probably what you're referring to. And I do think that most states have transitioned to, and most providers have transitioned to buprenorphine for that reason. About the increases in prescribing, I think that's a great question. I honestly, I don't know much about this issue. I know that there are a lot of issues with pharmacies trying to stock up on buprenorphine and running into problems. It's certainly an issue. It's not one that I personally study, but I think it's a great follow-up question, and I'd love to talk to you more about it if you want to follow up with me offline.
Thank you.
Mm-hmm.
Any other questions? Well, Jenna, that looks like that concludes the questions. We really appreciate your presentation.
Great. Thanks so much for allowing me to virtually connect with you.
Thank you.
Yeah. Just introduce from here.